How are you doing? Welcome, welcome, welcome. Nikisha, Katie. All right. I'll just wait up a little bit until a few persons join in. Hi, Amika. How are you doing? Welcome, welcome, welcome. Deron, Liz, DA. Happy New Year to you, Deron. Oh, Lord. How's your day going? How's your day going? I'm tired, My eyes them feel like them a locked down. My eyes them feel like them want locked down, me not lie. Okay, let me turn up this thing. Welcome on YT, welcome on TT. If you're new here, thank you so much. Resume. I'm planning to get on to nursing school soon, writing my T's next month. Okay, congratulations, Twizzy. Can't lip read. Oh, you're not hearing? I'm gonna have to restart the live then. Oh, it working now? Okay. Because it got disconnected. I wasn't so sure what was happening. All right, so I'm going to turn the camera so you can actually see the projector, the questions, and then from there we start our little session. For the T's, just go with the syllabus. Whatever it is that, I don't really know much about the T's exam because I never did one here. You know, I did my exam in Jamaica, so it's a little bit different than in the States here, too easy. So just go with whatever it is that they, I would say, is on the syllabus. Oh, for nursing school. Oh, for nursing school, I would say go ahead and get your pathophysiology book. Get a pathophysiology book and start read on your pathophysiology, because that is going to be your foundation. And from there, if you know pathophysiology, your life is going to be good for nursing school. That's the only thing I can say. Make sure you get your textbook for pathophysiology. Get your foundation and you're good. All right. You're welcome. You're welcome. All right. Let me turn the camera and let us try to... Oh, so some persons were asking me to go through some of the... These are some of the sepsis. I think I have about 8 or 10 sepsis question here. So I'll just go through them and then we'll go in some OB questions and some maternity question. All right. Oh, let me turn this. Flip camera. And as I said, the live streams are posted on YT at ThinkNursing. So feel free to go over to my YT page, subscribe, and get the full live stream. All the contents are posted over there. So just in case you missed the live streams that we've been doing. All right. So these are some case study questions again for sepsis. So we'll just go through them similar to, you know, questions that we've done before on sepsis, just different. The management for sepsis is going to be basically the same. All right. So let's go through this one. A patient with, it's readable, right? You guys are able to see it, right? All right, let's try and tap up the live a little bit. Let's tap up the screen and share with the live, guys. Well, let's try to get some more folks over here. It's clear, nice, too easy. Okay, good. Because I know sometimes the projector is a little bit weird. All right, so let's go. A patient with septic shock has the following data: blood pressure 84/48, 134. Oh. 84/48, heart rate of 122, lactate of 5.2 millimoles per liter, urine output 15 mils per hour. Which provider orders should the nurse carry out first? Select all that apply. Administer broad spectrum IV antibiotics. Start norepinephrine infusion. Infuse 30 mils of IV crystalloids. Obtain blood cultures and administer acetaminophen. So which order should the nurse carry out first? So you have this patient, septic shock, and the blood pressure is 84/48, tachycardic 122, lactate 5.2, urine output of 15 mils per hour. I see here, oh, let me turn this over. Okay, so I see here 134, nice. So administer broad spectrum antibiotics, infuse 30 mils IV crystalloids, and then obtain blood cultures. Oh, let me get my nice. Where's my cursor? Where are you? Do you see it? Okay. Okay. All right. So 134. So you wanna infuse 30 mils of IV crystalloids, obtain your blood cultures, and administer your broad spectrum IV antibiotics. So fluid is your first priority. In septic shock to restore perfusion. Blood cultures must be drawn before antibiotics, but antibiotics should not be delayed. So if you're not getting that blood, go ahead and start, your antibiotics. Vasopressors such as your norepinephrine, those are used after fluids if hypotension persists. Treating fever does not address the life-threatening issue. All right, so IV fluids first, then if your fluids not addressing the hypotension and it's persistent, then you go with your vasopressors. Blood cultures, you'll go ahead with that after your antibiotics, before your antibiotics, but if you're having problems with getting your cultures, go ahead and get your antibiotics. Nobody see it. Which patient should the nurse assess first? A, patient with COPD, SpO2 of 90% on 2 liters of oxygen via nasal cannula. The patient with type 1 diabetes with fruity breath. C, the patient with CHF reporting ankle swelling. Or D, the post-op patient requesting pain medication. So which patient should the nurse see first? The COPD, 90% oxygen, saturation on 2 liters via nasal cannula. B, the patient with type 1 diabetes and the fruity breath. C, patient with CHF reporting ankle swelling. D, post-op patient requesting pain medication. Okay, I see a few persons here says B, Sonam, B, V1, Sign, Simi-R, Carousel. Why are you guys thinking about B? Why B? Okay, so 2 dots says B, possibly DKA. Okay, yes, because of the fruity breath type 1 diabetes. Okay, but why not the COPD? We always talk about airway breathing. That one has to do with oxygen. Why not that one? The SAT is 90%, or the CHFO. That's an oxygen question. You're not concerned about those oxygen patients. Seroxan, 90% is expected for COPD. That is normal. SIME HR, because it is under the range. In COPD, SATs won't always be near 100. Okay. What's a good SAT for your COPD patient? What's the range you're looking for your COPD patients? What's the range for your COPD patients? Roxanne says 88 to 92%. Good. So that's so the COPD patient, the SAT there is 90%. That is acceptable. So no concern for that one. Cam, yes. All right, so Cam says C initially. Patient with CHF reporting to ankle swelling. Why would you go and see that person first though, Cam? I see that was your first answer. Oh, you say A or C. Yeah, why would you see either A or C? Cam? Yeah, you are correct, Roxanne, with your DKA. But Cam was saying A or C. I want to see why Cam was thinking along that line. The one says swelling in extremity is common in CHF patients. Yes. Is that right? Just for a little bit. Where's the timer?
I don't need timer.
Okay. All right. So the CHFO, the ankle swelling is expected. So that patient is not like say priority. The COPD, as we said, that is pretty normal for that patient. So B, the diabetic with the fruity breath, that one is, heading into DKA or concern for DKA. So you'll see that patient. So fruity breath, DKA, which can rapidly progress to coma. We know that is a medical emergency. So see that patient first. Your COPD patient is near baseline oxygenation. CHF is edema, edematous, and post-op pain patient are non-emergent compared to a metabolic acidosis patient. All right, let's look at this one. Let me take my time and go down before I see the answer. Okay. A patient in DKA has the following labs. Glucose 610 milligrams per deciliter, pH of 7.11, potassium of 5.9. Which actions are appropriate? A, initiate. That makes sense. Okay, so Cam says that makes sense. I saw similar questions before and it was CHF patient who was priority, but it mentioned increased swelling. Okay, so depending on the context of how the question is, you have to make sure you look at that as well. All right, so which actions are appropriate? Select all that apply. Initiate IV insulin, administer potassium replacement, begin isotonic IV fluids, place patient on cardiac monitor, hold insulin until potassium decreases. So you have this patient DKA who has the following labs. Which actions are appropriate? A, C, D, 1, 3, 4. Okay, initiate IV insulin, administer, which one we say? Begin isotonic IV fluids, place patient on cardiac monitor. Okay. What are some examples of isotonic fluids? 3 dots on a red car. Welcome, welcome, welcome. What's an example of an isotonic fluid? Yes, the 0.9 saline, your lactate, and the plasma. Yes. Jasmine said, I haven't gotten in that far in school. That's fine, Jasmine. You're good here. You're good here. Okay. All right. So 1, 3, 4. We're going to do IV insulin, isotonic fluids, place the patient on cardiac monitor. Why are you placing this patient on cardiac monitor? Why are we placing this patient on the cardiac monitor? Potassium is too high. So this patient is at risk for arrhythmias. So you want to make sure you have this patient on cardiac monitor to look for any irregular rhythm. Yes, this arrhythmia is due to potassium. Potassium is high, monitor heart rate. I see someone says, what 610 milligrams in millimoles? That's the glucose reading, the sugar level, Fabia. That's the glucose reading for the patient. 610 milligrams per deciliter. Okay, so definitely get the patient on the cardiac monitor. Hold insulin until potassium decreases. Did I just hear her say puppy? Israeli, I mix up. All right, let's go down. So initiate your IV insulin, begin your isotonic IV fluids, and place the patient on cardiac monitor. So potassium appears high but will drop rapidly once insulin is started. So always make sure you look at your potassium before you start your insulin. Okay, make sure you do that before you start your insulin. Insulin should not be held unless potassium is below 3.3 because it's gonna further cause it to drop and then put the patient at risk for hypokalemia. Cardiac monitoring is essential due to the potassium shifts. Which of the medication we're given that is causing the potassium to shift? Which of the medication is going to cause that potassium to shift that we're giving this patient? Is going to push the potassium to the to the cell. Is it the saline? 3 dots on a red car. The insulin, yes. So the insulin is gonna cause the potassium to shift. No problem. Not cause everyone is saying, oh, because everyone is saying insulin. Potassium replacement is not given when potassium is elevated. All right, because that is gonna further cause arrhythmia, send the patient 6 feet under. You don't want to put this patient in cardiac arrest. So the potassium is elevated, you don't need to replace the potassium level. So sorry, I meant what's the equivalent of this? Oh, we're gonna have to go onto the calculator and do that. Fabia? Yeah, I don't know it out on the top of my head. We're gonna have to go onto the calculator and look it up. But it's gonna be a bit high. Okay. So your DKA patients, what kind of ABG imbalance are these patients usually in? For your DKA patients, what kind of imbalance are they usually in? Tisha, welcome. What kind of imbalance are your DKA patients usually in? Metabolic acidosis. Okay. And if you had a patient who has hyperkalemia, how would you go about with treating this high potassium? You have a patient that has hyperkalemia. How would you go about with treating that hyperkalemia, high potassium? What would you anticipate in terms of the treatment for high potassium? Insulin, D50, dextrose. We're treating high potassium. We're not treating DKA. We're treating high potassium. So if you have a patient with high potassium, hyperkalemia, what are you anticipating? A lot of time persons are confusing DKA with the management of hyperkalemia. So while we're confused already, let's just kind of see where we're at. So we have K-oxalate, calcium gluconate, we have IV insulin, your dextrose, 50%. Nice. Latex. Okay, so that's the treatment for your hyperkalemia. I see protamine sulfate. Alino, what are you treating here? So protamine sulfate, Alino, what are you treating? So Alino, protamine sulfate is for your heparin. Is your antidote for your heparin. Okay. So if you're going to be treating your hyperkalemia, your high potassium, you're definitely going to need your insulin, your 50% dextrose. You're going to need your calcium gluconate. You're going to need your patient on your cardiac monitor, your K-oxalate. But if for NCLEX, you know, remember that is oral, so it's not going to be an immediate fix. So that is going to be later on. Okay, so you have to be careful when you see the K-oxalate there. And sometimes you'll see the albuterol. Be careful with that as well. All right, let's move on to the other question. Class 3. Hey, Tisha. Welcome, guys. Okay. Let's go on to this question here. A nurse is caring for a patient with acute pulmonary embolism. Before we go on, a nurse is caring for a patient with acute pulmonary embolism. What do we know about PE, pulmonary embolism? What do we know about pulmonary embolism? What do we know about pulmonary embolism? What are some of the causes? Associated with DVT. Okay. Shortness of breath. The clot travels from the legs. Blockage. I don't want to see any more DVT. Give me something else. Post-surgical. What do we know about DVT? Lack of ambulation, fractures, long flights can lead to pulmonary embolism. What do we know about Virchow's triad? Immobilized for too long pregnancy, yes. Clots that travels to the lungs and blood flow, okay. High blood pressure, 2 hours sitting. What can we use to confirm pulmonary embolism? What can we use to confirm pulmonary embolism? Or what is the definitive testing for pulmonary embolism? If you want to confirm a patient has pulmonary embolism, what can you anticipate the doctor to order? What is that one test that can say, yes, that patient has it? Let's see, Fabulous says, is it really the D dimer though? All right. Ultrasound. So pulmonary embolism. So what is that one test that will tell you that, yes, the patient has that clot in the lungs? The CT. Shuthema, CTPA, yes. The CT scan, you need a CTA scan, a CT angiogram. The Doppler ultrasound is going to show what? If you have a patient that has a pulmonary embolism, you're doing a Doppler ultrasound. Where are you doing a Doppler ultrasound? When you do a Doppler ultrasound, where are we looking at? What are we looking at? The DVT, okay. So deep vein thrombosis. So you're looking down in the leg, yes, Marquita. Okay, so that is not going to tell you that, yes, there is a clot in the lungs. So we are looking for PE in the lungs. We're looking up in the lungs. And I know I've had a few persons say the D dimer. So the D dimer is not going to be definitive, because you're going to have, if you have a clot anywhere, the D dimer is going to be elevated, but it's not going to tell you exactly where the clot is. So the one that is going to tell you that definitely, yes, it is going to confirm the pulmonary embolism is going to be your CTA. Yes, Bethat 20. Okay, so nice. So a nurse is caring for a patient with a pulmonary embolism. The contributing factors, you're going to select 2. I know we already said it, but you know, always pick your brain. So chest or lungs are we using the scan on? Chest and lungs, yes. So recent surgery, you're going to choose 2 contributing factors here. Recent surgery, asthma, prolonged immobility, or hypertension. So not legs, no Harley. If you're going to do an ultrasound on the heart, it's going to be for like your echocardiogram. That's the ultrasound you're going to be doing for your heart. So we have Recent surgery, prolonged immobility. Nice. AC13. Good. Yes, Harley. Looking for well, we were looking for pulmonary embolism earlier. That's what we're looking for. Okay, from that same question, potential complications, right-sided heart failure, hypoglycemia, sudden death, acute kidney injury. What are some potential complications of pulmonary embolism? Right-sided heart failure, hypoglycemia, sudden death, acute kidney injury. A and C. One, three, two of them carousel. So right-sided heart failure, sudden death. Okay. I see carousel says 4. Nefertiti says is 1C and 1C and 1, 3 and E. So for the first two, it's going to be recent surgery, prolonged, 1 and 2. So just in case you come on late. So the contributing factors are going to be recent surgery, prolonged immobility, where it said earlier. And then the second one, we're looking for 2 more. I've seen a few persons says right-sided heart failure, sudden death for most answers. So we'll go down to your recent surgery, prolonged immobility. Okay, the complications are your right-sided heart failure, sudden death. Let's look at the rationale. Pulmonary embolism blocks pulmonary circulation, leading to right ventricular strain. All right, large emboli can cause sudden cardiovascular collapse. Yes, Chine. User 228, they're at the top. You got it right, Alino. Good, good, good. Okay. Oh, this was a question. So the question started from here. Basically just identifying the contributing factors for pulmonary embolism and then the potential complications. Yes, Tisha, right-sided heart failure and recent surgery. And remember, if you come on late here, you can always get the full live streams on posted on YT at ThinkNursing. The full live streams are there, so you can watch them at your own convenience, just in case you missed this one. Okay, let's go on to another question here. A patient with heart failure is prescribed furosemide. What kind of medication is furosemide? What kind of medication is furosemide? Loop diuretic. Good. And what are these patients at risk for, Maxis? What are these patients at risk for? We use it for swelling, edema. Okay, nice. So for these patients, what are they? They're at risk for hypokalemia. Try Tris says hypokalemia, removes fluid, hypokalemia, yes. So which finding indicates that the medication is effective? So you have a patient that has heart failure. Which Which finding indicates that the medication is effective? So if the patient has heart failure, if this patient has heart failure and it's left-sided heart failure, how will you know that this patient has left-sided heart failure? Give me some signs and symptoms of left-sided heart failure. Give me some examples of left-sided heart failure. Let's differentiate between left-sided and right-sided heart failure. Left for lungs, okay. So left for lungs, let's hear what left includes now. So everything backing up in the lungs, pulmonary edema, crackles in the lungs, dyspnea. The coughing, the wheezing, the shortness of breath, yes. And then right is when you have the systemic backup. Thank you, Peach. Okay, so if the patient is in right-sided heart failure, what are some signs and symptoms are you expecting for that patient? So everything is in the rest of the body. What are you expecting? Peripheral edema. Peripheral edema. Oh, you can't hear anything? Right-sided edema, jugular vein distension, low urine output. The weight gain. Alina, crackles in the lungs would be where? The crackles in the lungs is going to be on your left, not on your right. Yeah. All right. The frothy sputum. Crackles are in the pantry. Crackers are in the pantry. Left side of the heart. Ascites. End with a heart. Okay. Nice. So once you're able to identify, hepatomegaly is another one. Once you're able to identify and differentiate between the left and the right. So L, left side, lungs, right, rest of the body. Okay, then you'll be able to better understand what is going on. So which findings indicate the medication is effective for furosemide in the management of heart failure? Select all that apply. Remember, for you select all that apply, do choose whatever you're confident with. You gain points for those. You don't want to put too much, you know, don't be too overconfident and then you lose points for it. All right. So select all that apply. Decrease lung crackles. Is that something that would be saying that you have effectiveness with your medication? So I see 1, 2, 3, 5 for Kristen. Joyce is 1, 2, 3. So always treat them as a true or false. You can put a tick beside that. Weight loss of 2 kilograms in 48 hours. The medication is supposed to be pulling fluid. Is that something that is happening? Can put a true or false, you know, can put a true beside that one. Increase urine output. It's supposed to be pulling fluid. So we could say what? True, right? Because it's supposed to be peeing a lot. So we can put a little tick beside that one. Increase potassium level. What do we know about furosemide? Is it increasing the potassium level or lowering the potassium level? Because we know it's, yes, so it's false. It's decreasing. It takes potassium out. So increase potassium level, you put a big X beside that one. Decrease peripheral edema. Is that going to happen with the medication? Decrease peripheral edema. Is the swelling going to go down with this medication? You're pulling fluid from this patient. Is that expected? So we'll say everything except increased potassium level. We can scream, we can jump, and look at the answers. So decrease lung crackles, weight loss of 2 kilograms in 48. Increase urine output, decrease peripheral edema. Okay, So loop diuretics remove excess fluids. Potassium decreases, not increases with furosemide. Weight loss is the best indicator of fluid loss. Okay. So once you get all 4 of those, then you're good to go. Poo stain, sugarcane, you got it as well. Nice. Tisha, you got it as well. Good. Okay, so let's move on to the next question here. Let me take my little time. Okay. So I have a patient that is receiving IV opioids. Put a few IV opioids. Give me a... put one IV opioid, or give me a name of an opioid that you know. Put an opioid below in the comments that you know. Give me a name of an opioid. Let's see, morphine. Another one apart from morphine. Oxycodone, fentanyl, tramadol. Good. Okay. So you have a patient that has is getting dilaudid. A patient receiving IV opioid has a respiratory rate of 8 breaths per minute, SpO2 of 88%, pinpoint pupils. What's going on with this patient? What's going on with this patient here? So you go in and see this patient. What's going on? I see everybody says C. Toxicity. Okay. So this patient is overdose. Okay. So what is the priority nursing action? A, apply oxygen. B, elevate the head of the bed. C, administer naloxone. D, notify the provider. So you notice this patient here. I see everybody says C, administer naloxone. Why not go ahead and just give the patient some oxygen? You realize the patient oxygen saturation is 88. Why you want to run and go and get an injection? Why not address the oxygen? Huh? Why you don't just give the patient some oxygen? That's what I'm saying, lovely. Why not go ahead and elevate the head of the bed? Right. Yes, lovely. Why not apply some oxygen? Yeah. Why not go ahead and apply some oxygen? You run gun for naloxone. Eh? Pinpoint pupils indicator. Non-invasive first. Chine Love Lace says non-invasive first. Keisha says delay in care. Address the underlying. Pinpoint pupils tell the overdose. Overdose need correction. Okay, nice. So remember, when you see the word priority, priority is always addressing the pathophysiology of whatever the problem is. Okay? So you know that this patient is having a respiratory depression. This patient is overdose. So what is going to fix that problem? What is going to fix that problem? The naloxone is going to address, is going to reverse that depression. So that is what the patient needs. You give the patient the oxygen, the patient is still going to be having that respiratory depression, because you can give up 1,000% of oxygen. It's not going to affect the respiratory depression that the opioid is causing on this patient. So you need to give the naloxone. So oxygen, elevating the head of the bed, that's not the priority for the patient. So when you think of the priority in any of your question, just think of the pathophysiology of the condition. So what is that one thing that you need to do for that patient to reverse whatever is happening? Naloxone. Think of just like, so for example, so for example, it was the first action. When you think of like first action, then you can always go ahead and say, oh, the first action for the nurse is probably gonna, apply oxygen or elevate the head of the bed. But what is the one thing that you need to do for this patient to reverse whatever is going on? It's gonna be that medication. When you think of a patient that has tension pneumothorax, What is the priority for that patient? You need to do a needle decompression. All right, so things like those, just find out what is the pathophysiology, what is that one thing that needs to, you need to do to fix the problem, and then from there, that is going to be your priority. First B, yes. So the first action is going to be to elevate the head of the bed. But your priority is to run, get that naloxone, and get it to the patient. So even if the patient is not on the oxygen, all right, even if the oxygen is not on, that naloxone is what the patient needs, because you can give the patient as much oxygen as you want. If you don't get that naloxone on, that oxygen is not going to do anything for the patient, because the patient is not going to be able to, take those deep breaths to go ahead and get that oxygen level up. All right. So the patient is overdose. We need to go ahead and get that naloxone. So signs of opioid overdose, respiratory depression. Naloxone reverses the opioid effects immediately. Oxygen alone does not correct this cause. If it's first action, why wouldn't it be oxygen? So tired of tired of this is saying, if it's a first action, why wouldn't it be the oxygen? So anything that is non-invasive, you always go ahead and start off with that. I meant like if the question was first instead priority, because it's a nursing action. Yes, so it's a nursing action, so just go ahead and do whatever it is that you can do. The oxygen, remember, oxygen is an order, so whatever it is that you can do without saying, oxygen is a medication. So whatever you can do that doesn't entail like an actual order. So even though, yes, you don't have a physical order as yet, whatever you can do in the meantime, just start off with that. So why would I give naloxone first and then oxygen after? So user 228, so the priority for the patient is the naloxone. So, when you're there at the bedside, you might find yourself putting on oxygen and doing everything, and it just happening all at once. But the priority is to go ahead and get the naloxone. So if it means that, you rush over and get your naloxone and run, come back and give that, and then you put on the oxygen, as long as you get your naloxone on board, that is the most important thing. Usually first is least invasive, right? Usually first. Yes, first action is usually the least invasive. Would be what you keep your patient. Priority is what you would do. Yes, what you need to do to keep your patient alive. If you did just oxygen, they're still getting that opioid, that's not addressing the issue. Yes, Marquita. So you'll stop whatever opioid they're getting, and then from there, you get an naloxone. Does naloxone have to be ordered by a doctor? Yes, it has to be ordered. Eventually, it's going to be put in by a doctor. Everything needs to be ordered by a doctor. So even on that emergency situation, you're not going to literally sit down and be waiting for the order to be in the system. You understand? Certain things are a given. You have a patient, there are verbal orders. So, but you're not going to see the order in the system, but everything has an order in the NCLEX world. It's going to be a perfect world you're working in. NCLEX, we always have an order. Sexy girl, yes, Ali, correct. So don't think of anything else happening. You're not short staffed, no lack of resources. Everything is just there. The order is there. In the real world, you don't have to think about, certain things. But in the NCLEX world, everything is with an order. The order is already there. Yes, Liv. Okay. So as we said, the answer is C. You go ahead and give that medication naloxone to reverse that that overdose. So it's respiratory depression. Naloxone reverses the opioid effects immediately. Oxygen alone does not correct the cause. So if you see low glucose, remember to go ahead and act. Low blood pressure, you need your fluids. Abnormal potassium, monitor your heart. Infection and hypotension, sepsis, okay? So always remember that. So low glucose, act. Go ahead and get your medications going. Okay. Low blood pressure, get your fluids started. If it's non-responsive to your fluids, then you go with your vasopressors. Abnormal potassium, then definitely monitor your heart. Get your patient on the cardiac monitor. Okay. If you have a patient that has infection, patient is hypotensive, think sepsis, and then from there. Okay. What time? Oh, I think that was more than 10 questions. Okay, let's do one case study for our OB. And then from there, remember to follow if you haven't done so as yet. Thank you so much for the follow. And like up the live, share up the live, and can check out the YouTube page when you get a chance. I think nursing for the full live streams that we've done so far. And I do pop on the live here on Tuesdays and Thursdays at 7 p.m. Central Standard Time. Okie dokie. We'll also do pop up on other days. But on Tuesdays and Thursdays is the one that we have on calendar. Okay? All right, so you have a 34-year-old who has Gravida 3, Para 3, delivered a 9-pound infant vaginally 1 hour ago. Oh, what are the answer choices? For which one? Oh, no, when I reach down there, say it's Elish. No, I'm going to pick on the brain first. Yes, I'm going to pick on the brain first. So the blood pressure is 88/50. Heart rate is 124. The fundus is boggy above the umbilicus. Lochia is heavy with clots. Perineum is intact. Urine output is 20 mils per hour. What are we thinking here? I see retained placenta hemorrhaging, hemorrhage, postpartum hemorrhage. This patient is unable. I don't know what you're saying there. Okay, so we're thinking about hemorrhage in here, postpartum hemorrhage. Nice. Unstable, good, because you see the blood pressure here 88/50. Heart rate is 124. The fundus here, it's boggy. Is it supposed to be boggy? Is the fundus supposed to be boggy? So this patient just had a baby 1 hour ago. No. So what are you anticipating for this one? So it's boggy. How do you correct this? It's supposed to be firm. How do we firm up this thing, Rose? How do we firm up this uterus there? Go ahead and massage the fundus. Good. Shy. Yes. So go ahead and massage the fundus. Lochia is heavy with clots. So the lochia is usually heavy at first, okay? It says heavy with clots, so eventually, you know, kind of slow down. Urine output 20 mils per hour. Is this normal? Is this a normal urine output for her? Patient need to void and massage. Is this a normal urine output? 20 mils per hour? No, small. It should be 30 mils per. Yes, shine love. Needs to be at least 30 mils. So we know that with the 20 mils here, the tachycardia, the hypotensive, this is not going good for this patient. All right, let's go down to this section. Which nursing actions are priority? So I already answered the question. OB emergency IV fluids, NC. I haven't seen you. Is it USC? Are you the nurse, the OB nurse, NC? I don't remember if you're the OB nurse that was helping us at one point. Okay. So what are the nursing action here? So remember, this is a priority question, and we just did a priority question earlier. So what is the priority for this patient? We just realized that this patient has PPH, postpartum hemorrhage. So the priority is select all that apply. 1, massage the uterine fundus, which you guys already said. Administer oxytocin IV. Insert indwelling urinary catheter. Apply ice pack to the perineum. Prepare for blood transfusion. What's gonna be your priority action here? 1, 3, 4, 5. 1, 3, insert indwelling catheter. Apply ice packs to the perineum. Prepare for blood transfusion. Okay. I see 1, 2. Administer oxytocin IV. Okay. So don't need 1, 4, 5. All right, let's go through them. So remember, as we say, always start with your true and false. So massaging the uterine fundus, we said definitely if this patient has PPH, we need to go ahead and massage, right? So we're gonna tick that one. What kind of medication is oxytocin? What is oxytocin? So oxytocin, administer oxytocin IV. So this patient has postpartum hemorrhage. Oxytocin, what is that gonna do? Okay, so contracting the uterus for contraction. So stimulates uterine contract. So 1, 2 helps uterine. So is that gonna help with your bleeding? So reduce bleeding. Let's see here, promote contraction. Okay, so we're gonna put a tip beside this one because that is gonna help with your bleeding there, right? So insert indwelling urinary catheter. Is that something that is a priority for this patient? Is that a priority for this patient? I'll put a question mark beside it. Apply. No. Belinda says yes. Okay. I don't think. It's not C-section. Okay. Chine Lovelace. Okay. Yes, because it's less than 30 mils. Abtamu. Okay. So since I don't know, it's 125 above 3. Not a priority, but low. That's what I was thinking, Jones. For me, it's not a priority, but it's low. So I would, that's why I put a question mark beside it. It's most accurate for measure of volume, especially with the fact that the patient is hypertensive and the heart rate is there. So eventually I would put in the catheter. So I'm going to put a question mark there. Apply ice pack to the perineum. Is that something that we would do? It's low, but it's not a priority, I think. Okay. So apply ice pack to the perineum. Is that something that you would go ahead and do? I don't know what I want here. No? Okay. Yeah. So maybe put an X beside. Belinda says yes. Perineum is intact as hypertensive. I think no. But this patient can't walk to the bathroom because of hypertension. No wonder, Wonder Man. No tier, no priority. Didn't mention nothing about that. So no apply ice to perineum. We're not gonna do that. And then prepare for blood transfusion. Is that a priority? So blood pressure is 88, heart rate 124. You know, Fundus boggy, I would definitely do that. So let's look at the answers that we have here. So massage the uterus. All right, massage the uterine fundus, administer oxytocin IV, insert the indwelling urinary catheter, prepare for blood transfusion. So this is uterine atony, boggy fundus, heavy bleeding, as we say. We go ahead and do the massage to help with that. Fundal massage and oxytocin is the first line intervention. First line intervention, your fundal massage and your oxytocin. Full bladder prevents uterine contraction, so the catheter helps uterus contract. So Shoy, it says full bladder prevents uterine contraction, so catheter helps uterus to contract. So they need to insert the catheter there. Hypotension and tachycardia, hemorrhagic shock, blood may be needed. So go ahead and prep the patient for that. The ice packs may be used for perineal trauma, not uterine atony. All right, so those are the rationale for that one. So this one, as I say, it would eventually come for me, but I'm not a OB. I'm not a gynae nurse, OB, labor and delivery nurse. So this one was a question mark. But the full bladder, it says here, prevents uterine contraction. So the catheter is going to help with the uterus contracting. Hope we got that. All right. Good. So the bleeding continues despite the oxytocin and the fundal massage. Oh Lord, that's a problem, right? What is the next most appropriate intervention? Administer methadone, administer magnesium sulfate, perform bimanual uterine compression, or prepare for hysterectomy. Oh Lord. So you have the bleeding continuing despite the oxytocin and the fundal massage. What is going to be your next intervention? So I see here, administer methadone, B, administer magnesium sulfate, C, perform bimanual uterine compression, and D, prepare for hysterectomy. So I see A, some C's, and yeah, we insert indwelling catheter causes the full bladder will cause sub-involution, hence bleeding. Yes, Erica. Yes. Oh, you're a registered midwife. Thank you for joining. Yes, that's what we learned earlier up the top. Because I was putting a question mark beside it because I wasn't sure. So catheter will make sure the bladder is drained continuously. Okay, nice, nice. Okay. So what's the next most appropriate intervention here for this patient? Administer methadone. I see administer magnesium sulfate. What kind of medication is magnesium sulfate? Because I see some persons put in B. So magnesium sulfate, what we know about magnesium sulfate? Okay, but in terms of the action, so we're thinking about the action here. So we use it in preeclampsia, we use it in eclampsia. Okay, it's a muscle relaxant. So if it's a muscle relaxant, oh, the question is here, Van Everard. So yes, and just think about it. So if it is used in severe asthma, we use it for dilating, okay? We use it in your high blood pressure patient. Okay, we use it in your eclampsia patients. So we use it for those. So if you're gonna give it to this patient that is bleeding, what is gonna be happening? We wouldn't want this because it will cause more bleeding, definitely. So I will put an X beside the magnesium here. Perform bimanual uterine compression. We already did the fundal massage, oxytocin up there. Performed by manual uterine compression. Is that something that would be the most? Yes, shy 03. So because the muscles are relaxed, then you're gonna have more bleeding. I believe when all else fail is when D would be necessary, right? Prepare for hysterectomy. Well, you know that I don't know if hysterectomy would have been like I would say probably. I would say, what would Erica, would D be correct? D would be correct. The answer would be A though. Would D be correct? No hysterectomy. Oh Lord. So the methotrexate is the second line, all right? That is the second line for uterotonic situations there. Magnesium sulfate relaxes the uterus and would worsen the bleeding. Bimanual compression may be done, but medication is next, and hysterectomy is your last resort. Jobs in Jamaica. Why is bimanual after the meds? Yes, why is bimanual compression after the meds? Let's Google that. Let's look up that. Bimanual compression is to cause pressure around the area the placenta is located. Until they bring them to the OR. You're welcome, Joy. Okay. So is that more invasive than the medication? Is this the only medication that can be given? Thank you so much, KLFCHI, NCLEX review course. Yeah, methotrexate, you wouldn't want to go ahead and do that with hypertension. Why you wouldn't want to do that with hypertensive patients? Wonderman. Why you wouldn't want to give methotrexate with your hypertensive patients? When the animals goes,